Hello everyone and welcome back to Medinos for Medicos. The topic that I have selected today is from microbiology Q fever, which is an important repetitive question asked in universities and vivas from by the external examiners. The objectives we are going to deal today is about knowing about what is Q fever and what is the causative agent of it, pathogenesis, the clinical features, how can we diagnose this in lab, control, and the treatment that we give it. So the causative agent of Q fever is Coxella burnetii, which is a gram-negative bacteria. This bacteria is a pleomorphic in nature, coccobacillary, and obligate intracellular bacteria. It might occur in two shapes. It can either be of rod shape or it can be spear. Now, if it is in rod shape, the size would be at the range of 0.2 to 0.4 into 0.4 to 1.0. That is the um, breadth would be 0.2 to 0.4 and the length would be 0.4 to 1.0 micrometer, and the spheres would be of 0.3 to 0.4 micrometer in diameter. When you go to the pathogenesis, the source from which we obtain this fever is acquired by human beings is by sheep and goat. The direct cause transmission is by consumption of infected milk, and then we have the indirect cause, that is by inhalation. So the people who are more prone to this is if like it is an occupational disease also, so it might be in people who have the occupation of handling wool, hides, meat and other animal products that have contamination with this organism. So what happens over here is when we have the direct consumption of infected milk or we have the inhalation, um, the entry of Coxella burnetii happens, and then we have the endosomal maturation, making the bacteria metabolically active. So what happens is that we have vacuole acidification that occurs, after which we have LCM system that becomes uh, functional, and this effectors modulate host response and they stimulate vacuole biogenesis, after which the bacteria replicates and then it enters through the abrated skin, mucosa, lungs and intestinal tracts, and then it gives the clinical symptoms. So the next we have the clinical features. So what are the clinical features? Usually the clinical features, the first things they would be showing is the patient would show headache, fatigue, malaise and muscle aches, abdominal pain, nausea, vomiting, high fever, chills and or sweating, loss of appetite and all. In extensive case, it is characterized by intestinal pneumonia, which is the reason we would be having abdominal pain, nausea and vomiting. It can also cause hepatitis, meningoencephalitis, endocarditis, and sometimes it is asymptomatic in nature too. Now for the lab diagnosis, firstly we need to ensure safety, because this is a very infective bacteria, and it has a biosafety class 3 cabinets for it. Uh, and the sample that we collect would be either blood or the tissue culture, and for the direct microscopy we use Giemsa stain. So the Giemsa stain would cause it to turn into purple color. Basophilic inclusions would be colored into purple. Then we have the Machiavello stain that would cause red colored inclusions. We can either do we can also do immunofluorescence, immunohistochemical methods and immunoenzyme methods. um, when we go for the culture, we have the cell and tissue culture, that is we have to do the isolation in containment laboratories, which I said we have biosafety 3 laboratory cabinets, and then it grows well in 3 to 5 days, and it it is done basically in varocell or MRC 5 cell cover slip cultures, and we can also do it in yolk sac of embryonated hen's egg. When we go for the serological test, we have immunoassays as well as wheel Felix test. So in immunoassays, we can either do ELISA, we can do immunofluorescence, we can do passive hemagglutination of red cells sensitized by ESS, that is erythrocyte sensitizing substance, rickettsial suspensions, and then we can also do complement fixation test. When we go for the wheel Felix test, we have to do the wheel Felix test over here would give O antigens of certain non-motile protease strains, and this agglutinates against the O antigens. And the strains that we use over here is OX19, OX2 and OXK. So based on the sharing of an alkali stable carbohydrate antigens with some rickettsial, this occurs, and because of this what happens is the antibodies, they appear rapidly, and the titers, it would reach up to 1 to the ratio 1000 to or 1 is to 5000 by the second week, and it would no longer be preferred due to cross reaction and cumbersome process. The next is the molecular methods. We will be using the rickettsial DNA, which can be done by the PCR method. Now we have the control. In the control, we need to know that the eradication is utterly impossible, and in endemic areas, the person that is entering should wear protective clothes. So we know what is a protective clothes, it's a PPE. So next is the treatment. The drug of choice for the treatment is doxycycline. We can also give them ciprofloxacin, tetracycline and chloramphenicol. However, we should avoid the use of penicillin and sulfonamides because it is ineffective. Also, sulfonamides is contraindicated in this. So that was the video for today. I hope you like this video. If you like this video, don't forget to like, share and subscribe to the channel. We'll be coming with more videos. Till then, stay tuned and happy learning. This is Ashnavi Raju signing off for today. Bye.